For those of you who have insomnia, or if you have friends who are on Facebook who are claiming that they can't go to sleep, I have the perfect solution for you. CMS 1734P, also known as the bill, or that has the physician fee schedule from Medicare, that will guarantee that you'll go to sleep after trying to read that document. Of course, I didn't have time to read it all, but I do have someone who has gone through it with a fine-tooth comb. He is no other than Mark Painter from PRS Consulting. He is known as the guru when it comes to urology coding, billing, practice management. So let's get him on here so that we can talk about the changes in CMS's physician fee schedule and how that impacts urology practices. Thank you so much, Mark, for coming on so early on a Sunday morning.
Oh, thanks for having me, John.
All right, let's get right into it.
Sure.
1,355 pages, it's easy document, easy read.
Walk in the park. There you go.
but you are used to it. And there are some major changes that are happening with our physician fee schedule in 2021. What are some of the major takeaways?
So there were a lot of things that were obviously stated and summarized, and you've probably heard a lot of them as you've gone through with some of the summaries. So I'll tick through a few, and then maybe we can go in and find and figure out why they came out with the numbers that they did. So, obviously, focused on urology as you're reading through this. The big change that's going to impact every practice is the change in E&M codes. They changed not only the descriptions and how everybody's going to have to use E&M codes and the documentation, and which, by the way, I think most every physician is going to love once they really get a good handle on the E&M codes and where they're going to be. It's just it's a physician-friendly change. But there are some nuances that everybody's going to have to learn, because associated with those changes were increases in the work RVUs. And the way that CMS really looks at the physician fee schedule is they start with any changes they know are going to happen to the RVUs that are out there, and they kind of layer those things in. So the work RVU changes in the E&M codes, because they are such a high volume of what Medicare pays for everything, is automatically going to impact everything else in the fee schedule. Now, those of you who have seen us talk about this before know that we've had a few things on the back end that have been being addressed over time that are specific to the non-facility practice expense RVUs. And one of those areas that they were looking at really in depth were scopes. And so some of those changes also rolled through. So when we look at the impact across the board of the RVUs going up and the way that urologists have billed over time, you've got a kind of a combination of two things. Number one, the conversion factor that they've projected they are going to use for next year is going to drop $3 or 10.6%. That's a big drop across the board. But when you take into account the way the volume of service is and the mix across the board with the work RVUs and the practice expense RVU adjustments, urology is projected to see an 8% increase. Now, a lot of people are kind of confused, like, how can you drop the conversion factor by 10.6% and still see an 8% increase in urology? Well, so there's two things that you want to look at from kind of the hidden perspective or behind the scene. Number one is urology in CMS's eyes when they run this is every urologist that has a taxonomy of urologist, right? So every urologist is amalgamated into looking as a single urologist. And so they're just going to use that urology as a urologist and project the overall payments. And that's what's going 8% up by 8%. But within that, there are serious winners and losers, because those of you who are doing facility services. So if you're doing everything in the hospital or the ambulatory surgical center and you're relying on that full fee coming back to you, everything you do is going to be reduced on the surgical side, and reduced by maybe not a full 10.6%, but for a lot of what you do, you're talking 5 to 8% on everything you do is going to be dropped. Now, your RVUs, and ultimately they look at the E&M codes as being the same, right? That the mix is going to be the same. But with the rule changes, they may not be the same. They may be higher, which actually, depending upon your understanding and how well you document, could help that offset that impact of the way the RVUs for your procedurals hit. Now, the in-office stuff, most of the in-office procedures that urologists do went up. Urodynamics went up. Everything you do through a scope went up. And some of your like Resume or microwave went up, as did Urolift. So a lot of those things went up. Now, John, I know one of your favorites is the vasectomy code. Unfortunately, that's going to take a slight hit as you look into next year because of the conversion factor decrease. So, hopefully most of those services for you are in the private sector world. So you got a little bit of time before the non-Medicare payers pick up that fee as they move it forward, or you got a contract that carves it out at a certain level. So, you still got those impacts that are there. So anyway, that was probably way too detailed on what you're looking at there. And I guess I'll add just one more thing, and that is the work RVUs for most of what the urologists do did not change, except for the E&M work RVUs. So those people who are on contract work RVU production rates, as long as who's ever paying doesn't adjust what they're paying you per work RVU, you're actually probably going to see an up for a little while. If those institutions start to get a little bit of a handle on the fact that they saw a drop in your income, that may come back and bite you somewhere. So it's one of those that we'll have to see where that is, but that usually takes a little bit longer.
Oh my gosh. I think most people are probably pretty snowed by now, because just within the first 2-3 minutes, that was so much packed in what you just said. Okay. I'm gonna try to roll it back a little bit.
Okay.
See, the E&M changes have not, the evaluation and management codes have not had much change in over 20 years, right? 1997, the rules. Right. So they are changing the way we need to document when it comes to E&M. And that came down from the CPT editorial board. The CMS has adopted it. And also the RVU, the relative value units assigned to each of the, all of the E&Ms from 99202 to 205, and then 211 to 215. So right. In office stuff that we're talking about, the office visits.
New patients and established patients.
You got it. So the documentation requirements are changing, and also the value that is placed on each one of the codes is changing. It actually it's going up. And that has implications across the board, because urology is not the only specialty that uses E&M codes. So people need to remember that this CMS game is a zero-sum, budget-neutral type of a setup. So when you have winners, somebody has to lose, right? So when you increase the RVUs, the cut has to come from somewhere.
Right.
And the conversion factor is what's taking a hit. It's going from $36.09 to $32.26, and that's a 10.6% decrease. And like you said, how can you have that decrease, and yet CMS, Medicare, is saying that urologists are going to have a net increase overall of 8%.
Yeah.
And then you said that CMS is looking at a representative sample of urologists and then categorizing that as urology.
Right.
And
yep.
And there are some winners and losers, like you said, depending on the type of work that you do. So facility and non-facility. A lot of people don't understand what that is. Can you kind of quickly explain facility?
Sure. So if you perform a service or a procedure in your office, there's only one bill that goes out the door, and Medicare only pays one bill, or reimburses one bill. So essentially, the facility payment and the physician payment are wrapped into, and that's place of service 11. Our office is typically that way. Now, when you go to the ambulatory surgical center, oh, and that, by the way, that is a non-facility payment. And then the facility payment is if you go to the hospital or the ambulatory surgical center, they're going to pay the hospital and ambulatory surgical center, whichever place you're in, they're going to pay them a separate fee for the same procedure you did. So they cut the fee that you are paid as a physician to the facility payment fee, because you're not buying the supplies and you don't have to support the staff. All that payment goes to the facility. So those are the ones that are taking the hit, are the things that you do in a facility, ambulatory surgical center or the hospital. Those are the ones your professional fee is going to take a hit.
Okay, so basically, if you do stuff in your office, that is in general. In general, if the stuff that you do in office, you should be looking at the non-facility fee column on the Medicare physician fee schedule. But those things that you do in the surgery center and the hospital, that's what's considered facility. So it's important to make that distinction so people can understand, because it is nuanced. In this case, when you're looking at RVUs, work RVUs, and then conversion factor, a lot of people are going to be lost. And just in general, how much physicians are paid is basically total RVUs multiplied by the conversion factor, if you're talking about Medicare.
Correct.
And that's why you say, go ahead.
Yeah, I was going to say with the geographic adjustments, right? So, yeah.
Yeah, GPCI, geographic something
Cost of
index.
practice index.
Yeah.
Yeah.
So understand that total equation is total RVUs multiplied by conversion factor multiplied by GPCI. That is your net payment for whatever the physician does, either in a facility or non-facility. So we need to, make sure everybody understands, because Mark, you and I tend to talk on a fairly high level, but and we immediately think of the nuances, but I think a lot of the audience are just starting out. So I want to make sure they understand the implications of what you just said in those first 2 or 3 minutes.
Yeah.
Also, you said there are winners and losers, and it's important to, I guess, reiterate, and CMS is kind of driving the nail in the coffin, that stuff that we do in the office is going to be more rewarded, if you will, compared to stuff that we do in the facility. And you said scopes like cystoscopy and Resume and Urolift, those things that urodynamics, those things that we do in the office seem to be going up, and that's how Medicare is figuring that urology is going to get a urologist, the prototypical urologist is going to get an 8% increase. And you said vasectomies. Fortunately, last year I can't remember a single Medicare vasectomy patient, and also vasectomy is not a reimbursed procedure for Medicare beneficiaries anyway, so it doesn't really matter.
Right. Yeah, it doesn't, unless you're indexed to a contract.
Correct.
Yeah, which could potentially hurt you.
Right. If your commercial contract is based on what Medicare's fee schedule is, then you may take a hit on your vasectomy reimbursement. But the old adage that PRS has been saying, and I've been saying, that the OR is nothing but an expensive hobby, it's really, really coming to the fore right now.
It really is. Now, another thing that's a little bit of a nuance in all this stuff, in that, the overall RVU package, as the way it goes really wasn't negative for most of the procedures you do in a non-facility setting. So it's the conversion factor that hurts everything, which is, across the board applies to everything. So even if something went up 5% on the RVU side, it's still a loss with the conversion factor reduction. So it is going to be a mixed bag, I think, if you look at indexing private contracts to the RBRVS here. And again, probably more nerdy than most folks want to really drive into at this point in time. But in reality, this is a good RBRVS year for urology. So if you can get the RBRVS without the conversion factor for contracts moving forward, this is a great one. It's the conversion factor that's the real killer, and because of that, Medicare, which is a huge part of a lot of urology practices, is going to be something they're all going to have to look at.
And just so that people understand, if you have a private payer contract that is based on the upcoming 2021 physician fee schedule, that PFS is valuing the services higher via the RVUs, but the conversion factor from CMS is lower. So if your private payer contracts are based on the RVUs and your private payer contract conversion factors is same or maybe goes up, you're actually greatly benefiting.
Yes.
But now let's talk about the facility side. Let's talk about the employed physicians who are going to be impacted, but may not be right away. So that it's quite nuanced, but people need to understand what may happen to them so that they can start planning, because it may not hit for a little bit while. And just for those people who are watching on Facebook Live, if you have any questions, please leave them in the comments, and I'll be sure to pass it over to Mark. So, Mark, if you don't mind addressing the nuance that may occur to the employed physicians, for instance, the hospital employed physicians.
Right. So if you look at the work RVU, and most contracts that I've seen for employed physicians have a fee schedule base that they're paid per month, and then they have a work RVU bonus, or they're paid on a dollar per work RVU basis. So again, if we go back, the work RVUs did not change. There weren't a lot of change. I mean, there were a couple of moves here and there, but the reality is they were pretty much unchanged moving forward. So your contract, if it stays the way it is going to be fine, right? If you look at it in the bubble of work RVUs and production units. So, but the flip side is when you look at where the actual income is, and that would be to the employer, and now all of your, we'll say the majority of the revenue that comes in to that facility that employs you, and not every employed physician is a total facility-based physician, so this doesn't apply to everyone. But in the end, if your income is down relative to your production to the gross level of income that comes into the employer, and that's a good possibility based on the fact that you're now being paid on the facility rate instead of the non-facility rate. The accountants and the bean counters, as they see things coming through a year down the road or 2 years down the road, may look and again come back to you saying, you're a money loser for us as an individual, so we need to negotiate your contract differently. We're going to take down your base, or we're going to take down your RVU, or take down your bonus structure. So that is a possibility that's coming down the road for a lot of folks. And you've seen this before, where the hospital bean counters, it takes them a little while to go through and watch all this. But they are going to probably keep an eye on this, and it's going to increase the pressure on top of COVID and the hits that a lot of the big hospital systems took. There may be some pressure on the employed physician's contract to get some changes.
So what I'm hearing is, for the hospital employed physicians, their take home for the individual may be based on just work RVU, which is, some may say that it's the best indicator of the amount of production that a physician does. But the payment to the facility, the physician's employer, will see an overall decrease, while what is paid to the physician may not decrease. It may even go up because it is based on work RVUs, and the physician may hit that bonus level much easier. But in a year or two, when the hospitals catch up, they may realize, hey, you know what, we are net losing, just if you're looking just at the production, RVU production from the physician. Hey, we're losing money on you. What adjustments are we going to make? Am I hearing that right?
You are. That's exactly right.
Okay.
So,
So it may take about a year or two to catch up, but the employee physicians need to be aware of how that may happen, not now, but then in the future, as the accountants from the hospitals figure that out. And again, it's if you're working in a facility setting. So if your practice is purchased by the hospital, it's now it's owned by the hospital. It's considered a facility when you see patients there. So the implications are also there when it comes to the conversion factor, when it comes to the RVU production.
Yeah, it can be depending. I mean, there's a lot of ways to set that up, but in most cases, you do have that physician campus structure that there is a facility fee. And so, yeah, that's very true. It's something to watch for. So I don't know if you want to move past that and talk about some of the other changes. Or
yeah, so E&M is so huge, right? That there are documentation requirement changes, and then the PFS changed for 2021. Thankfully, that appropriate use criteria is tabled. Do you want to kind of talk about that real quick? Let's switch off of E&M. And for those who are watching, again, feel free to ask any questions in the comments. And also, if you are interested in additional training when it comes to evaluation and management issues coming up in 2021, PRS Network has set up a workshop, actually a series of workshops that are coming up in September and October, and culminating in the Urology Advanced Coding and Reimbursement Seminar at the end of this year in December 4th and 5th of 2020 to really summarize everything if you are interested in a much deeper dive. So feel free to I'll leave the link in the video description for those courses. Let's switch on over to appropriate use criteria, Mark.
Sure. So there's the appropriate use criteria, which those of you who have came to our seminar and or have followed some of our articles, is a requirement by Medicare that was implemented in 2020, and they termed it as a test year. So with 2020 was a test year, so it was required, but there were no penalties for not playing right off the bat. So their original proposal was that in 2021, at the beginning of 2021, and all of this had to do with, did you go through extra steps before you ordered advanced imaging? It's probably the quick nutshell version of AUC and what it applies to. So what Medicare has done is they said, we're going to just extend the testing period one more year because of everything we've had with the public health emergency and the SARS COVID event. So so that's been extended. Now, in the end, we'll have to see what that is and how that comes through. There's still a lot of fight against that. And because it's and John, you and I were just kind of briefly talking about it before we jumped on, but it's administrivia. I mean, if you're actually practicing urology the way that you should be with medical necessity, it really doesn't help you like decide not to do anything or to do anything. You've already gone through all these hoops, and now they're just forcing you to go through these extra hoops to click through a few buttons and tell the actual image reader or provider that you did these extra things, which is it's another thing that just is extra because there are a small percentage of physicians out there that are abusing the system.
So appropriate use criteria is I don't even know why they even have it. Do they think that there are a lot of physicians wasting resources by ordering tests that are unnecessary? I just
Yes.
don't get it. So the operation and operations and education testing period, that's what you're talking about.
Yeah.
We've been going through this for about a year and a half, or 2 years now, and
Yeah.
it's currently non-punitive, meaning you're trying it out, you're trying to get your workflow and everything set up correctly. I turned that on for my EHR briefly, and it was just another, as you said, administrivia, another
Okay.
unfunded mandate that another hoop that we have to jump through, and it's another one of those nuanced things. The physician doesn't really need to do it. It's either the physician or the APP or his or her designee, or I forgot the language that they use, but somebody else can do it.
Yeah.
Without that code, the radiologist does not get paid. So we
Eventually.
are doing the work to get the code so that we can order the test so that somebody else can get paid. And without jumping through the hoops, then we may be penalized. Or if the tests that we order do not fit whatever criteria that they use in the future, after they look through the data, urologists or physicians may be subject to prior authorization
Yeah.
burdensome task. So that, or I don't know. It's yet to be determined what penalties that they're going to impose on those who fall outside of the norm, if you will, when it comes to
Yeah.
AUC. It's insane. And also, how do you get, if you don't get those codes from the EHR, then you have to go through some portal so that you can go through that clinical decision support mechanism, also known as CDSM, that the viewers may hear about when it comes to AUC. So that is not coming up until 2022, January 1st. So stay tuned for that one.
Yeah. We'll just keep an eye on it and see where it goes as it goes through all this stuff. And so, by the way, as we're talking about that, so um, we do have some pushback. So, because you brought up AUC, there's pushback in two areas right now that are major. One is, of course, AUC. Um, the other area of pushback is the surgical specialties who are looking at taking big hits are lobbying for a suspension of budget neutrality. And you remember that we've been down this road before with the conversion factor for 9 years. We've had kind of a 2-year window where there's been no real big push, complaints about MIPS, but in the end, the conversion factor hasn't really fluctuated. Everything's been relatively smooth, small adjustments here and there. Well, here we go again. And we'll see if there's any movement there. So those are kind of the big two within. And then the third big movement place is, everybody had, the experience of telehealth during the public health emergency. And now CMS in the proposed rule is trying to come back, and they have to come back within their rules to what they can and can't pay for. And so that's the other big push. So that we do have some controversy around this final rule, and that I just wanted to bring up that the unfortunate piece of where we sit right now, because they were 6 weeks late in releasing the proposed rule. They're not going to release the final rule until right about Thanksgiving, which will give us 30 days to react to any changes, and there could be some big ones in the final rule. So, John, you and I, when we get ready for our advanced urology seminar on December 4th and 5th, are probably going to be burning some midnight oil going through that final rule to get it up and into so we can get everybody and that final impact in for everybody that joins us for that seminar. So it's going to be an interesting fall as well.
I've said this before. It's amazing how PRS Consulting and you and Dr. Painter and Scott can host these seminars, essentially talking about the same thing, and yet it changes because the government changes, the rules change every single year. It's just insane.
It is.
Okay,
It is very much.
you mentioned the budget neutrality thing. Boy, that would be a huge that'll be a huge win for the physicians because of the pandemic and everything else that's going on. Everyone's revenue took a hit. Hospitals, they even furloughed some physicians, and physicians are taking pay cuts. If they can suspend that budget neutrality clause, that will be an awesome thing. So let's, I guess, contribute to your specialty lobbying groups, and hopefully that impacts positively for everyone.
Yes,
You also
absolutely.
you also mentioned telehealth. There's some changes in telehealth. Would you mind going over that?
So, yeah, it's kind of interesting the way that proposed rule was written. So, first of all, there's the read between the lines and the way the proposed rule was written. It was there were a number of codes that were added to the approved telehealth list. So they really are trying to expand telehealth, and they very blatantly said that the Medicare experience was very good with telehealth. Um, they went, by the way, from 14,000 telehealth visits a week to 10.6 million over a 2-month period when
Wow.
COVID struck. So they really turned the lights on fast. And the experience overall for patients was very positive. So that was blatant. Now what they've kind of written in the rule is a set of codes that are considered temporarily approved, Category 3 telehealth codes, if you will, and but it was written in a way that says that those codes will be part of the approved list only through the end of the year in which the public health emergency has started. So, and so a piece of what I took away from that is that we can expect, because right now the public health emergency that gives us the flexibility to provide telehealth services to the patients in their home expires on October 23rd. Now, the main reason is that, and that odd date is that when the public health emergency is declared, it can only happen in 90-day chunks. So the next 90 days expires on October 23rd. So if they say another 90, that puts it to January 21 of 2021. So basically, the way the rule is written almost assumes that we're going to see the public health emergency move into at least the first quarter of next year, if not further. So that's kind of one thing that was interesting, that these rules are written almost assuming that we're going to have telehealth the way we have it right now all the way through the end of this year. So that was one thing that I thought was very interesting. Then the other and the fact that they're really trying to push and expand, but they also very quietly in the whole side of this thing said, yeah, we still can't cover place of service home unless we have a change in Medicare law. So once the public health emergency is over, we're back to the old rules for video, for true telehealth, for audiovisual, in which the patient has to be in a Medicare approved facility, which takes down a ton of stuff.
Yeah.
Now, the other thing that they said that was kind of interesting, and they're waiting for comment or feedback. So another place that you can actually jump in and write Medicare is telephone only visits. During the public health emergency, the 994, 41, 42, and 43, those values were bumped for telephone only interactions. So you didn't have to have the audio visual to meet the 22, 23, and 24 values, or 213, 114. So the same as your office visit audio visual codes, basically saying the audio visual for an established patient is not that much different between audio and audio visual. Well, Medicare's kind of taking a step back from that and saying, yeah, we're not going to pay for telephone only visits when they move forward. So if you found that useful, you're going to need to write Medicare to get some help. And then The other thing that I'll mention is they did extend the CTBS. So that's the communication technology based services, not telephone only, but a lot of the interaction that happens over time. You've got principal care management, which is out there as a code that could be used with interaction with phone and with email. You've got your G codes that we're talking about before. There's going to be some expansion and remote patient monitoring, and some of the definitions that are there. So they're extending where they can, but they're also, in the way they wrote this, trying to put some pressure on Congress to make a real change to allow for telehealth to be provided in the home, because without it, you're back to that audio visual isn't really going to be that applicable to many people within Medicare.
Yeah, again, wow, just a couple of minutes and so much thrown in there. First of all, CTVS is Communications Technology-Based Services when it comes to Medicare. And when it comes to the Category 3 codes, those, thankfully, relative to urology, those codes apply to ED, domiciles, and I think nursing homes or rest homes and stuff like that. So thankfully, that won't impact on urology as much. And the big thing you said was the audio and visual versus audio only type of telemedicine visits. Medicare is essentially going to remove the parity in payment between audio only and audio visual type visits. So once that parity goes away, the voice only type of telemedicine visits, the payment will go down. Am I hearing that right?
So it's a little one step further in that they're not going to cover those at all. Not only are they going to take away the parity, they're not going to cover.
Yeah, the 41, 42, and 43 codes. Got it. Yeah.
Yep.
So and also this is, by the way, the 1734P. It's an interim rule, if you will. It's the proposed rule. Yeah. So it's not quite written in stone. When, like what you said, 30 days before our 30 days before the end of the year, that's when the final rule will come out, the permanent rule. So we now still have the ability to comment to CMS until I think the middle of October and voice your opinion on whether or not this is a good or bad idea. So personally, you can do it, or if your specialty society can also do it as well. So all is not lost yet.
Yep, and nothing's set in stone yet either. I mean, that happens on the final rule.
But what is the probability of most of this going through?
Oh, high.
Yeah.
I mean, they're really high. I mean, the proposed rule, we've seen a couple of major pivots by Medicare in the last 2 years. And one of them, which is the big impact this year, was the E&M. Remember, it was I think it was 2018 that Medicare proposed we're only going to pay 2 levels of E&M codes, and the whole world went ballistic, and that's why all this scramble changed everything. So that was one that they proposed and backed off on. But most of the time, what we see in the proposed rule, the track history is most of it goes in.
Now it's I think almost 3 years now. Time flies. Medicare in the in 1734P, they clarify the position on documentation. We've gone back and forth on who can document the history and some HPI and stuff like that, but they reiterated some of the things that they said about documentation requirements. Would you mind going over that?
So for last year or for this year coming up, that basically the documentation requirements for who records a history and physical and who records the HPI for the E&M codes was one that actually was proposed last year and put in finally at the beginning of last year. So this year, you've got leeway as to who does HPI and who documents history and physical or history and actually can start the physical exam. And next year, with everything set up the way it is, all you need is a medically necessary, HPI history and all of that. So they did do some clarification there. And they also, as you look at one of the things they did was CTBS and some of they are extending the reach of what can be done by supervised personnel um, across the board. From what I'm seeing, and they're adding new codes. The principal care codes, the G0265 is an example, and the G0264, where you've got that extra involvement with the patient for a single significant disease, kind of a chronic care management piece. Now can be done by the physician and or by the staff. And there's two different codes. They pay two different levels. So they're really trying to extend what the physician can use his or her extender for. And a lot of that has to do to just with reaction to how busy, urologists are across the board, and how do we keep patient access up? And one is give the physician another pair of hands.
Yeah,
and another head to do stuff.
Yeah, the one I think you're referring to how the APPs, the certified nursing specialists, the certified nurse midwives, may now supervise certain diagnostic tests. Is that something that?
So that's one thing, but there's also with the CTBS stuff, and we saw this during the SARS, that with the CTBS, the ability for your MA, as an assistant to you, to be the one that actually touches base with the patient on the phone over a monthly period, and actually charge for that without the physician having to pick up the phone or send the emails. As long as it's supervised, there are now codes, those G codes, that they've added for those.
Yes.
That's what I'm talking about. Yeah.
Got it. Yeah. There's so many, there's so many telehealth codes that came out, I think, March and then May. It's like 2 or 3 changes within a 4-week period. Back then, it was insane. You mentioned a little bit about remote patient monitoring. That is going to be going back to, or continuing to, or they reiterated that it's going to be for established patients only.
Absolutely. All of the telehealth and remote stuff is pretty much going back to established patient only. A lot of the verbiage that's in there, in the codes themselves, remember, was overridden for the public health emergency. So those are going back into play. Good, yes. They feel that, and they explain very clearly that, with remote monitoring or with any of the CTBS, that it is critical that there is an established relationship. It's worked out okay over this time period, but all that's coming back into play.
Lots and lots of changes. All right. Last issue here. Direct supervision. That apparently is going to continue until the end of 2021 for the interactive telecommunication, using interactive telecommunication technology. So that's kind of an important thing, so that physicians can use remote.
Yeah, and they're looking at making that permanent. So that was one of those category 3 things that they really felt like, why not extend the supervision capabilities of the physicians on a direct supervision side? So that is officially, as far as the proposed rule is, going to be extended. But that sounded to me, as I read through that's kind of an interim step to making that maybe final over time, given the technology leaps. And one other kind of nuanced one that was in there is they did say that if you're doing audio visual within the same facility, that you can charge it as if it happened face to face.
But that's changing.
Which was interesting. No, they're actually going to keep that you'll be able to, if you were in the hospital and you saw an inpatient visit within the same facility using audio visual, you could actually bill it and continue to bill that as if it were a face-to-face, not with the audio visual modifiers. So
nice.
So that was, I don't know how often that's actually going to work. Why would you be in the hospital and not go see your patient? But Obviously, with COVID, you would.
Well, hang on. I think one use case is the patient may not want to come into the clinic, but they want to stay in their vehicles.
So yeah, so that one would make some sense if they were right out front, and we could. And right now we've got some leeway to use the parking lot, but there are some potential issues, and this is. I think I've actually got a question the other day. Is like, hey, we built a new suite across our parking lot. Is that the same facility? I'm like, well, does it have a separate NPI number? Yes, it does. It's not the same place. I mean, yeah, it's in the same complex, but it's just like in the hospital. You can't be operating and have your office upstairs and still see patients in both places. So you got to be careful as to, we go that what is the same facility. Right now,
Yeah.
we're okay in the parking lot, but we'll have to watch that.
Well, I think that I don't know. There's so many because not everyone has 4G or Wi-Fi access that can do the interactive telemedicine type thing. Not all patients do. So if they don't feel comfortable coming in, I just saw a lady who was not comfortable coming in, didn't want to come in to have an exam and have drop out her urine. So if those people don't have Wi-Fi or 4G, and they don't want to be, come into the office, then the parking lot might be a safe option. I think that instance is going to be rare, though.
Yeah. Well, and I mean, reality is, as long as those types of issues are live and real, which you're going to see in pockets. Probably, and I think this is kind of the way CMS was hinting at and wrote the rules that public health emergency extending, into, the third quarter of next year is, very likely at this point. So I think we're gonna see that ability for a while, and it's going to be interesting to see how much Congress and the legislature, with an election year coming up, can they do anything with telehealth? You would think that could be a win for both sides, that they could potentially push through. Will it happen? I don't know.
Yeah. The
wins are tough.
Yeah, the Republicans recently said how Trump extended the telehealth services, but that kind of reverted back to requiring it being in a designated specially designated site instead of being able to do it at home. So
Right.
It doesn't. We're not. The patients are not going to be able to realize the benefits if they're during the current public health emergency, if they don't want to travel, if they're afraid to travel, or if there's still a higher risk of infection, especially Medicare patients, right? These are older patients, and they are that at-risk group. They tend to have comorbid conditions and things like that. So I can understand the concern, but I hope the both sides can come together and come up with a good plan so that it would really, truly benefit the beneficiaries instead of just talking points.
Yep. If you could actually just address, one issue instead of hanging a few other things on everything that went through, maybe it's got a shot. We'll see.
Yeah, yeah. Well, a lot of people don't understand, when a bill is actually introduced, is not just this is the only thing we're changing. It's just a bunch of pork projects that are attached to the bill so that both parties can agree, because you're getting what you want and I'm getting what I want. And that's unfortunately what happens with these bills. So,
Yep.
Anyway,
pork and poison pills. So
that's it. Pork and poison pills. All right. Any last words? We're running quite long, and I thank all the viewers for hanging on for so long.
Yeah. So I think those are the main things we wanted to deal with. Again, we're going to have a short reaction window. I know we didn't cover MIPS and MACRA. That's something you definitely want to take a look at to see where you are there. So there's a lot more in it. It was 1,400 pages. Even though you gave me an extra 20 minutes to ramble on about everything that's there, we did not cover it all. I think we got some highlights for you. And hopefully everybody joins us on the E&M training sessions we've got.
Hey everyone, I don't know what happened. The streaming software cut out, but you did not miss anything. We were wrapping up anyway. So for those of you who are interested in attending the PRS 2021 E&M Workshops coming up in September and October. I will put the link in the video description, as well as CMS 1734P to guarantee that you go to sleep without any problems. Until then, take care. Bye-bye.